Welcome. This is a Globe Op Talk. For those who haven't done one of these before, these are conversations that Globe Editorial Board members have with world-leading experts and surprising voices. And it's my pleasure today to welcome Dr. Paul Farmer, who is our guest for this Op Talk. Paul Farmer almost needs no introduction. He is a pioneer in global health. He is the founder of the organization Partners in Health that works around the world on infectious disease and indeed on the social inequities at the root of much of the impact of global disease. He is also a university professor at Harvard and the chair of the Department of Global Medicine, is that right? Global Health
and Social Medicine.
Social Medicine at Harvard Medical School. Paul, Dr. Farmer, it's so great to have you here.
Thank you, Bina. It's an honor to be here with the hometown paper.
With the hometown paper, and we're lucky to have you in our hometown. So I want to just start by asking how you are and sort of what your life has been like in the COVID-19 pandemic. I imagine you might have something in common with some of us, but that your life has been markedly different than many of ours.
Well, I mean, I'm here, and grateful for that. I have seen quite a bit of loss and experienced some in our family as well. So it's been difficult. The work has changed very dramatically for many of my coworkers as it has for so many people. One of the things that you know very well about is that a lot of our attention, and my attention as a clinician, has been turned towards Haiti or Rwanda, and since 2014, Sierra Leone and Liberia in responding to Ebola. And a number of my colleagues, many of them who trained with us at the Brigham and Women's Hospital or at one of the other Harvard teaching hospitals, many of the Americans came back and are now working for the first time since they were in their training in Massachusetts on contact tracing. And it's really about a lot more than contact tracing, of course, but that's been a big shift for them as well. So with the exception of a very brief trip to Haiti, again, under unfortunate circumstances, my father-in-law passed away. The biggest change for me has been, sitting still in Boston. And global health isn't usually like that. I mean, Boston's on the globe too. So of course, my colleagues came back to pitch in Massachusetts, and they're all still, and Partners in Health is of course still working in Haiti, Rwanda, Malawi, Lesotho, et cetera, everywhere we had been prior to the epidemic. So, just to summarize, for me, it's been unusual to sit still. There's a lot of work to do in Massachusetts, of course, and across the United States. There's also the work that's gone on in each of the 11 countries where we work to fight COVID while maintaining other operations, which are much more broad and clinical. So that's been what my life has been about for the last 3 months, COVID.
I'm very sorry to hear about your father-in-law. That is quite sad news. And I also want to just say that I think you gave the Globe a new slogan. Boston is also on the globe with that response. So thank you. How does it look from your perspective across these 11 countries, as well as working here in the Commonwealth, which we're going to get to and talk about contact tracing? But what's your sense of how this pandemic is unfolding, where we are in the pandemic, how different countries are dealing with the impacts?
Well, I'll start with the United States. I mean, back when I wrote that piece for you about expert mercy, that was at the outset of the epidemic. And unfortunately, a number of the feared complications of this pandemic have come to pass already in the United States. So we don't have to talk about a second wave right now because we're still really stuck in the first wave, which doesn't show signs of retreating if we look at this using the nation state as a way of looking at the epidemic here. In Massachusetts, we've seen a lot of improvements, which are worth celebrating. But with 26,000 cases a day, nationally, if that's the right number, we really can't say that we're, seeing the end of this first wave in the coming weeks or months. And then, case by case, we're accustomed to thinking transnationally, of course, right? Epidemics don't respect boundaries, and pandemics are by definition, spread across the globe. So using the nation state has some, shortcomings, right? Because these are regional epidemics. How different are Northern Italy and Southern Italy? How different are places that are contiguous or bound by connections of trade? But, we're seeing, in Peru, for example, where we've worked for 25 years more, with, what seemed to us to be some serious preparations, they nonetheless they are having a very difficult time. Rwanda, on the other hand, where I was at the beginning of the epidemic, has been organized, and in part because they were facing an Ebola outbreak on their western flank, and with the border with the Congo. So there was already a great deal of activity around things like infection control, contact tracing, public health reporting, but they have a very good system that they really built from scratch after the genocide. And they have been, they've done very well. They've had few deaths and a remarkably small number of infections, probably compared to Burundi, just across the border. And I could go case by case with all the places that we work. I'm very concerned about Haiti, where there's inadequate testing. And who knows if Rwanda will be able to continue along these veins. And the list goes on and on. I won't run through the countries. We do that every morning or 6 days a week, though. Partners in Health teams meet from Russia all the way to Peru, to say how things are going. And one of the main reasons that we should do that is because we need to make sure that people have the staff and the stuff and the safe space and the systems necessary to confront the disease. So there's a lot of fatigue among my coworkers, but they're doing their best, and even when the results are not what we would wish, they're a very impressive group of people. And that's about 18 or 19,000 people working with Partners in Health.
Wow, that's an impressive number indeed. Can you say more about Rwanda? I'm gonna pivot to your beautiful op-ed in a moment, but the idea that Rwanda has, or your comparison really of Rwanda and Burundi, and you're seeing a lot of success in Rwanda. Are you attributing that mostly to prevention and awareness of basic public health measures? Is it more about the social awareness and sort of norms around disease? Why do you think?
I'll just say all the above. The typical explanations for variation in a population, either genetic differences in the host, the humans, or in the microbe, none of those would explain such a difference, of course. We really have to look at social organization, political will, that slippery concept. And on those scores, again, I tend to go materially and look at staff, stuff, space, systems, and support, just so I can keep in my mind kind of a checklist of what we need to be looking for. So staff, for example, Rwanda has per capita many, many more times the community health workers that we have in the United States. They have weaknesses just like every country, and certainly every poor country, but they also have strengths. And those programs to put in place community health workers able to help respond to epidemic disease or non-communicable disease. Rwanda has that much more than most other countries. So that means that they have good policy around health. And that's been the case for almost 20 years. And that was a clear political calculation and a moral one that the way to claw back from the genocide was to invest in health and education. And I'd say that they've been the stars of public health really for 15 years. They have seen the sharpest declines in death from AIDS, tuberculosis, and malaria ever documented anywhere at any time. And they've also seen the greatest gains in life expectancy, drops in child mortality and infant mortality. So it's not an accident, right? And it's not a cultural difference with comparing Rwanda and Burundi. They share the same language, and as far as I can tell, the same culture. Now they might not agree. They might say, no, we speak Kirundi and they speak Kinyarwanda, but I think a linguist would say they share a culture. So, you know, in my line of work, my academic work as opposed to my clinical work, that's what I look at, is what are the factors that promote or retard an epidemic as it moves through a population, or in this case, a pandemic. So these are very complex claims of causality, right? A causes B. And you really have to think, how do these 10 factors cause the kind of responses that we're seeing? Because really the microbe and the hosts are going to be very similar, I think.
Fascinating, especially because when I think about the scale of US investment in medical innovation and in healthcare and how expensive, we have the most expensive healthcare system in the world. And to think a country with far fewer resources has just invested them more in community health and shown the art of the possible. It's fascinating. So I do,
you know, if you need, I was just gonna say, if you need a heart transplant, go to the Brigham, right? But if you need community-based care, our country, even our best teaching hospitals, we just don't have the infrastructure that is required or reflects the vast amounts of money that go into American healthcare. Now, I'm not saying that everybody should go out and work in community health centers or be a community health worker, although a lot of people probably would like that job right now. At least that was the case when we opened up applications for contact tracers in Massachusetts. Within hours, we had hundreds, if not thousands, of applications. So we can't blame a lack of interest in community health and well-being on American culture, for example, if there is such a thing. We really have to look at how we allocate money for our own staff, space, and systems, and support. And support is the key, to expert mercy, if I can, use that term again. It's really the support that linked to the right intervention that is some kind of expertise and one hopes based on science. It's the support that makes a difference. And there again, Rwanda has made some significant strides, I think, compared to the United States in the amount of social support, given its tiny budgets, that it's willing to put into health and education.
So by support, you really mean investment?
I mean investment, yeah. I mean, when we talk about the specifics of COVID, about how contact tracing can work, it really needs to be focused on how can we support people who were asking to isolate themselves. They need food, they need water, they need shelter, they need TLC. So support is investment. Part of the investment is, the investment of caring about your neighbor, including the unknown neighbor, someone you've never met before. And I think that can be palpable inside medicine and inside public health, but it can also be palpably absent or rare.
So I want to dig into that a little bit more, because I think that certainly relates to your concept of expert mercy, which, thank you for writing that great Globe op-ed in an earlier stage of the US part of this epidemic in March. And you talk about expert mercy as being this combination of science and compassion, and that we need both of those things to address outbreaks. Can you, I guess, zoom out from COVID-19 for a moment and just explain how that concept of expert mercy in the other outbreaks you've dealt with around the world, from Ebola to tuberculosis to AIDS, how has that concept practically been applied or practically been useful?
Well, I learned about this in Haiti as a young man, as a student. The notion of accompaniment, which I would have associated with music or, just a generic kind of term. But it meant something special. And that experience in Haiti in the 80s was in part around contact tracing, believe it or not. I'd never heard the term contact tracing until I was a medical student, and I got lucky enough to work as a contact tracer, a Haitian-speaking contact tracer, for the Department of Public Health on tuberculosis outbreaks. And I learned so much in Haiti, and I'm still learning things from Haiti. But by the time the earthquake happened in 2010, which is not an epidemic, of course, an epidemic, many of them ensued, including what became the world's largest cholera epidemic. But really, you know, if you're sitting there in Port-au-Prince, and which has, you know, been laid waste by the earthquake, including its medical facilities, especially its medical facilities, and you see people trapped under buildings or with crushed limbs, what is expert mercy there? Well, we had to ask that question because had been there already since the early 80s, and people were asking us, well, how can we help? And we said, the kind of help we need surgical teams with, you know, surgical teams with anesthesia, you know, a complete surgical team, a trauma team. That's what we needed as expert mercy at that time. And going to Ebola, which 4 years later hit West Africa, and that really launched Partners in Health in West Africa. We knew that we were going to go in to take care of patients with Ebola. And expert mercy in that case often requires critical care, and it always requires supportive care. Now here I'm using the term supportive in a different way. Supportive care doesn't really mean hand-holding. It means that if you're short of fluids, it means an IV. If you know, can't breathe, it means an oxygen mask. And so the term, and it means largely nursing care, right? But that's what people needed in the Ebola epidemic. Sometimes they needed critical care. Some of my friends who survived Ebola, Americans, they received expert mercy by being airlifted out of West Africa back to the United States, and none of the Americans died, and very few Europeans died, or people who were airlifted out. So what happened as the ground moved beneath them and they left West Africa and went to Europe or the United States is the quality of the care, critical care that they needed suddenly was available. Now, COVID isn't entirely different, as we've seen. It does require supportive care, IV fluids, oxygen, and critical care for some, meaning intubation and sometimes renal, dialysis, really. So the terms shift, but I think that's why it's important to say that the mercy part of it is always constant. Can we be more merciful and kind? The expertise will change.
Can you say more about that? Because part of what you're saying might, for just a person listening to you, sound like triage, right? Either you're giving someone the critical care in the moment. Obviously, there are real disparities in what's accessible to an American who contracts Ebola abroad versus someone in the Congo right now who's contracted it. But what distinguishes that kind of medical triage of what kind of care is needed in that situation from your concept of expert mercy?
Well, I mean, just to go back to the Haitian earthquake in 2010, what would be the short-term expert mercy? Again, trauma care, and there's invisible trauma, of course, mental health services, which always get neglected, by the way. But really, should Haitians have to be airlifted from Haiti to sort of survive? We certainly did airlift a number of injured people. A lot of them were children to American hospitals, but that's not really a long-term solution. So a long-term solution is having that available in Haiti. And that's the reason we built a huge academic medical center called the University Hospital in the middle of rural Haiti. And people, not Haitians, they were the Haitians were saying, this is great, but a lot of the experts that had a criticism of this said, well, why would you, this is not a priority right now to build an academic hospital. And this is right after all of Haiti's academic medical centers had been destroyed. So who's training the nurses, who's training the doctors, who's training the health managers? So we built this medical center, University Hospital, in a place where people would also say, yeah, but there's no university there. And we said, yet, because that's another part of expert mercy, building local capacity and building local expertise. So I am very proud of my Haitian colleagues who I haven't seen in months except for a funeral, because they are delivering expert mercy in a solid, beautiful facility with the staff, space, and systems and support that they need to do their jobs. So triage is not a bad concept, right? But you have to go from when you're critically ill or injured, you need a hospital, right? When you have obstructed labor, you need a hospital. What about when you have a chronic illness? Or what about a situation where people are afraid to go to hospitals, as with COVID and Ebola? You know, there, expert mercy often does involve community-based care. And certainly isolation, you know, that shouldn't happen in a hospital room, right? That should happen in someone's home, or if they have elderly relatives who, I'm talking about COVID again, they have elderly relatives maybe in some place that's decent and nice, like a Sheraton room that's been, you know, offered for that cause. So I think triage sometimes gets a bad rap. The question of triage across a national border, we really need to be building local capacity, and that includes training programs and university programs like the one in Haiti. So I know it's a mouthful, but triage, you shouldn't have to send someone to another continent to get basic supportive and critical care.
And it strikes me that if you were just looking at how to locate medical expertise in Haiti in that moment, you could use criteria like where's the biggest population center to do that. But this sort of relates to, I think, what has been a mission of your career, which is who are the people most vulnerable or most in need, and how do we situate that expertise and that medical capacity where people have access to it? So that seems to go hand in hand with that. So I do want to come to contact tracing, because Partners in Health, for anyone who doesn't know, is leading the effort here in the state. Governor Baker called on you specifically, Paul, to help lead this effort and develop this effort. And leaving aside, I do want to ask you about sort of the question of the timing of that and where we are and when you think this is going to be the most impactful. But leaving that aside for a moment, since we're talking about expert mercy, how does this concept get applied to a situation where what you're trying to do is identify contacts of infected COVID patients? You're trying to help people stay away from maybe friends and family members at a time when we've all been social distancing for quite a long time. How does the alchemy, as you've put it, of science and compassion factor into how to do contact tracing right?
Well, you know, I told you that I had this long history of interest in contact tracing from my student days and from working with tuberculosis. But I can also say in the years since then, in the decades since then, during the height of the Ebola epidemic in West Africa, when people asked me, hey, what, you know, stopped Ebola? I said, you know, because it had started in eastern part of Guinea, which is right next to, if you look at a map, it's right next to Liberia and Sierra Leone. And, you know, the answer to that could be, well, the Atlantic Ocean stopped it, because it went all the way from the, you know, what were called the forest regions, which are increasingly deforested, went all the way there to the coast where the capital cities are and other large port cities. But so it is true that the failure to flatten the surge, the term that we were discussing in Boston in March, the surge was not flattened. And to see an entire healthcare system taken out like that in a matter of weeks or months is a very frightening thing. And in the end, close to 1,000 healthcare workers lost their lives in that epidemic, that 3-country epidemic. But what stopped it at the end? How were the last, you know, cases identified and cared for? And that was all contact tracing. At least that was my impression from northern Sierra Leone, close to the border, or closer to the border with Guinea. Just watching, you know, is you know, basically you have a patient, and this is how it works with COVID too. You have a patient who has a confirmed test. Then you talk to the patient about their contacts. And that's called a contact list. And that sounds very dry. And one of the reasons that people won't always accept it is because there's a lot of mistrust of institutions in many countries, including this one, including the United States, right? There's a distrust of some national institutions. But ideally, everyone who then is identified with either Ebola or COVID, just to use the 2 examples, they will be on that contact list, right? You see someone, let's say Mrs. Sella, who is identified and has a a positive test. And she's on the contact list as being a contact to her coworker or cousin or mother or daughter, husband, who has already been identified. We are very, very far from that. And my colleagues who are running I should say first that we're not running anything so much as working with the public health departments. There are 351 of them, local public health departments just in Massachusetts. So we're trying to echo and amplify what they're already doing and have been doing valiantly for a long time, but they just don't have the wherewithal. They don't even have the wherewithal that Rwanda has in terms of community health workers and contact tracers. So we're very far from getting to that point where we can say everyone who's now falling ill is on that contact tracer list. And that is one of the reasons people have said, what about the timing? Shouldn't this wait for later? And we just, we were asking when Governor Baker and Jim Kim, I just want to single him out because Jim Kim was really helped us to lay down the arguments as well. But when we went in there to work with the governor and his team, we were asking a much more modest question. We were asking, might this help? And we knew the answer was yes, it might help. And we believed it was going to help. And I hope that we'll be able to say Massachusetts continues this downward trend. And the more resources that are put into contact tracing in the humane expert mercy sense of saying, we got you. See, that's the message that you have to get out, that you're on the side, we have to be on the side of the afflicted, but the message is really, we got you. This is to help you and your family, not this is to document, to control you in any way.
Yeah, I mean, I think that's an important distinction in the way the Commonwealth and Partners in Health has approached contact tracing here. And in a way, it's kind of ironic. Here we are in one of the technology centers of the world, biotech center. We're certainly, we have satellite headquarters of Google and Apple and Facebook and all the rest. But that this is really not the South Korea, China approach to contact tracing, which has relied mostly on cell phones to identify people who've been in contact with infected patients. And so can you say more about why you think that this approach why is this the approach that you made the case for? And why is it the approach that you think ultimately, when the timing is right, will be what helps us get out of the epidemic?
Well, let me just start, Bina, by saying, I am all for a technological intervention that could make this work better. I've never seen it work without that we got you attitude of expert mercy. I've never seen any public health intervention work in a heavy-handed way, in not just the United States, but in Haiti and lots of other places that don't have a lot of cultural similarities. Even Rwanda, which has, the reputation of being able to roll out interventions from the central government. I think that, they need to believe that this is the Ministry of Health, as it's called around the world, that the Ministry of Health is doing this work in order to protect them. And that takes time to build up. Like you could imagine after the genocide that was not the case, that there was, if there was anything in short supply in the affective realm, it was trust. Right, and so I'm all for having technological assistance, and I believe it could be helpful. For example, in 2016, there was an outbreak of mumps at Harvard, or it was based at Harvard, and one of my colleagues, a former student, if I can brag, who's a Harvard medical professor, Party Sabeti, is an amazing person. Right? She showed me just recently, looking back at the contact tracing data and compared that to contact tracing plus some of these technological interventions. That's such a vague term, and I'll return to it in a second. And what she suggested, or those who worked on this suggested, is that contact tracing actually did identify most of the contacts, right? But that new tools actually could enhance the yield, if you would, on contact tracing. So we're waiting for that. But some of these interventions are not tried and true yet, like proximity sensors. They're based on Bluetooth. I don't know if they, yet if they work or how they will work. I'm following some of the development of these apps in various countries. All of us are. We're trying to look to the UK, to some of the Scandinavian countries, to Asia, of course, to South Korea, China, and looking at them and saying which ones of these could be useful. But there's a great deal of debate, as you know, about these apps. And some of the debate is really not about, does this invade my privacy? Some of the debate is still, does this work? Right. So again, back to, could this help? Which I think is a fundamental stance of humility. Could this help is a humble question. And if the answer is, it might not, then you could say, well, then we won't do that. But if it might help and it doesn't do harm, I think plowing ahead with a human-based, human-centric, human design is at least a legitimate way of proceeding. And if there are smarter ways that come along soon, we'll snap them up or push for that.
All right, maybe we'll come back around to this. I do want to invite Chris Avello, who is the Globe's Director of Subscriber Experience, at least until he leaves us on Wednesday, which I'm devastated about. He's going to join us and ask some questions on behalf of the audience members who submitted them in advance and who might be asking them right at this moment. Hi, Chris.
Thank you, Bina. Thank you, Doctor, and hi, everyone.
Hi, Chris.
I won't comment on my imminent departure. This is more important. But I do want to take a brief moment to quickly say thanks to all the Globe subscribers, and readers who are watching right now, and there are hundreds of people watching right now, and many submitted questions. So thank you, everybody. We couldn't do this without you. So let me dive in. Are there any hopeful precedents for solidarity in the wake of disaster that perhaps we can learn from presently?
Well, you know, I mentioned already the most radical and profound transformation that I've seen has been in Rwanda. So that really, to me, tells you something, because it took me years to confess publicly in Rwanda that I was one of those people who in 1994 thought this country is never going to come back from this. But they did, and they have. So how do you do that? It's not just great central planning and deciding to elevate healthcare and education as priorities. It also requires an enormous amount of nitty-gritty work at the community level. These are villages, small towns. You know, people are aware now that Rwanda has the largest fraction of women parliamentarians in the world. But, you know, just to see that on a village level is just an incredible thing. And I lived there 10 years, and two of our kids were born in Rwanda. So that already for me is, I'm not going to let anyone tell me that you can't find solidarity after catastrophe. Now that's what concerns me, Chris, in our own country right now. You know, when I wrote that piece for you guys, the epidemic really hadn't hit Boston. I don't think, at least when I drafted, I know that people weren't wearing masks or social distancing. All that came after. But unfortunately, the social inequalities and social disparities of American culture shaped the epidemic. And again, I would be hard pressed to find other epidemics. I'm talking about the American epidemic. I'd be hard pressed to find other examples where that wasn't the case. But over the last 3 weeks, you know, there's been so much solidarity, and we should look at, you know, expert mercy could also be called pragmatic solidarity, right? Because the solidarity may be the most noble sentiment that we have access to, but if it's not linked to something when people are clamoring for food, you know, housing, sick pay, the chance to not live in fear in this country, if there's no pragmatic intervention to go with that, then it's, you know, it's so much fluff, right? And then, you know, I was thinking when I reached out to you this morning, I was thinking about Brian Stevenson's book, Just Mercy, right? And inside the entire system of punishment, you know, the judiciary, prisons, jails, the whole schmear inside there are also calls for expert mercy. Brian Stephen himself worked on a blue ribbon commission, I forget what it was called, under Obama, and they submitted 40 pages of expert mercy, meaning recommendations that were no doubt highly technocratic, some of them, that would be designed to address the catastrophe that is our carceral system, and to grow solidarity instead. So again, to go from Rwanda after a genocide to the troubled history of race and class in the United States may seem like a bit of a leap, but I think there's always, as I learned in Rwanda, there's always the possibility of atonement, repair, apology, and rebuilding. But those processes have to happen in this country as well. I'm sorry if I went on too long, Chris.
No, not at all. And this actually, it's good. This next question is related, and so many people asked different flavors of this question. I just chose one to read, but how can we convince non-mask wearers and people who are ignoring social distancing guidelines to do the right thing?
Well, I think there are lots of ways not to do it. If you look at the public health literature on shaming, it's a mixed bag, right? Secondhand smoke. That was a legal case, right? That was according to Alan Brandt, a historian in our department, he traces, there were vast social changes, but it was a legal intervention. And as a friend of mine who may be watching, who's a theologian of global health, Jenny Block, she's a disability rights activist. She said every advance that we made was legislated in a court. So I'm just saying, I'm not advocating that we make it mandatory. I'm just saying sometimes when you say this is required, it's not optional. Once we have the data, because don't forget, we gave very mixed messages about masks at the beginning. I was guilty of that. The Surgeon General said, masks in the street are not necessary. And now people are saying, well, maybe the reason Japan has a smaller epidemic is that there is a longstanding custom of wearing masks whenever you have or around people who have a respiratory illness. And so I'm not a fan of shaming. I wouldn't do it. That sign on the door that says, you have to have a mask to come in here, I think that's okay. That's saying this is for everybody. And that may seem like an extreme recommendation, legislate it. I'm just saying the rules and regulation approach can have a expert mercy effect too. To dive into Ebola one more time, Bina, you've empowered me. I remember those months when the greatest pain that many families experience was not being able to bury their dead, which in many religious traditions is the last act of caregiving, right? And they were the ones providing most of the care, right? The great majority of care was provided by unprotected family members who did not have PPE, right? So they fell sick too, and many of them died. And this was very difficult. I remember at the height of the epidemic, it didn't work to say, they passed laws, they had roadblocks, but people still buried their dead or tried to, right? It was really the enforcement of those laws. I talked to people over years, by the way. This is not just casual conversations with patients. I talked to patients for years after they recovered and while they were still sick, and some of them expressed frank relief at being prevented from meeting their social obligation to bury their loved ones. And I didn't see that coming either. But I think that many Americans are frightened right now, and they should be. If we have 26,000 cases a day, and it's going up in 7 states, we should be frightened. So we want expert mercy in this case to sometimes tell us what to do. And I think that every intervention, social distancing with acknowledgement that many people cannot socially distance, they don't have the material wherewithal to do it, masks, if it could help, again, then we should push it forward. And, again, that would be better than shaming, I think. I don't know if I answered the question, but I'm thinking about it a lot.
I think you did. And so amongst the questions, there were many people here who were just sort of saying thank you, and a couple of people called you a hero. So with that, there was a couple of people who want to know, how do you sustain your kind of energy and compassion for what you do?
Well, I work with a lot of people, and I learned in the '80s when I was still a student that, and going between Harvard and Haiti, and on one end of that trajectory, I saw the power of tertiary medical care, right? What we, expert mercy when it requires, I even got hit by a car as a med student, and, and remember thinking, I was in Cambridge, and I remember thinking, I'm going to be fine. I'm going to go to the operating room. Once they told me I would have to have surgery, and I got transferred to the Mass General from another hospital. I just knew that I would be fine, right? That I would survive. But on the other end of that trajectory, I happened to be going there the next day. I would have gone there the next day, Haiti. On the other end of that trajectory, I saw so many tragedies that could have been averted with an adequate medical system. So back to the question, when you work with people, a lot of people, and over a long time, and you develop friendships and strong relationships with them, you got each other's back during difficult times. I would not have made it through the earthquake, without the help of friends. And I mean, emotionally, mentally. And that also, so that's an important thing to realize, that, anything you do in this line of work is going to require teams and partnership. And once you get that down, you realize you don't have to be the one who's always, full of pep or vim and vigor. And we help each other out a lot that way, I think. So that's to just demystify it a bit. People don't come in here with endless reserves of energy and optimism in difficult times. Also, I've been very uplifted in this particular spring by the response to the murder of George Floyd. I mean, to see, I'm going to say millions, because it's hundreds of thousands anyway, but to see millions of people in this country and around the world respond this way, again, to me, that tragedy did something to spark an awareness that was absent in the first months of the epidemic. And so, again, that may seem like a strange thing to say, but, seeing Americans respond with revulsion to that and ire, and now we need the plans, the real implementation of a radically different way of proceeding, as we do in American medicine. But these are things that kind of can get you, in my experience, can get you going again, And then finally, and perhaps most honestly, if you stick with something for a long time, you are going to see tragedies sometimes. Like if you work in Haiti for 35 years, you're going to, and you realize that there's not enough in the way of basic medical care in much of the country, then you're going to see tragedy. But if you build a tertiary hospital where there isn't one, well, that feels good too. I was there this week. I was there on Sunday, and just seeing it loom on the horizon, and the 1,000 purposeful Haitians running that place is inspiring to me. So I guess that the take-home message there is, stick with something long enough, work with good people, and you'll make it through.
That's great, thank you. And I think I will probably end it on the subscriber questions there. So thank you everyone again for submitting them, and thank you, Doctor, for answering them. We really appreciate it.
Thanks, Chris. Good luck in your new venture.
Thank you very much, I appreciate it.
We'll miss you, Chris. Thank you.
Bye, guys.
Thanks for helping make OpTalks a success. Chris was instrumental in launching this series. So Paul, if you have just a couple more minutes, I'd love to ask you at least one more question. And one is that I think you've talked about social cohesion. In fact, we put it in the title of this talk. And I think we're in a time of social distancing. We're recognizing with COVID-19 the stark disparities in the United States and clearly around the world. And we're also in this moment of incredible social activity, social movements being activated, political protests, but it is also not the case that everyone in our society sees those through the lens that you see them through. Do you have a prescription for how we get through this time of the pandemic, how we get through this time of social upheaval in a way that protects social cohesion?
Well, I think going back to Brian Stevenson, I think acknowledgement of a lack of social cohesion in its roots is one of the best things to do to build social cohesion. At least that's what happened in Rwanda. I was there living in Rwanda when they launched an initiative called Gachacha. And again, this was I was working in the prison, somebody had to, right? And in one of the prisons, they said, yeah, I followed a patient into the prison because I had been saying in our early years there to the community health workers, contact tracers, when you have a patient with a chronic disease like AIDS, say, and he or she starts on therapy, you see them regularly every day at the beginning, right? And then they would come in with these stories that were true, right? Like the patient left for the Congo, or but the first time someone said patient got arrested, and I said, this is an old trick. Okay, let's go to the prison. And they said, the prison director, and in this prison, this is the largest prison in Rwanda. It was in this rural area where we were working, 11,000 inmates, maybe a few more right then. And if you went in, you saw on the board that 70% of them were there on genocide-related charges. So what happens inside a crowded prison, right? Epidemics are a serious problem. In any case, the Rwandans, the authorities, but at a community level too, realized that warehousing 300,000 people was not a viable option for Rwanda. And I don't think it would have been a viable option for any country with those resources of that size. That's a huge, and remember, I'm not saying they weren't guilty. I'm saying, what are the alternatives to incarceration? And for them, they started this process called Gachacha. And I secretly thought, you think that there's not going to be a violent response to having people who are perpetrators stand up in the village and acknowledge what they did when people are saying, and you threw the body there, or you dumped it down there. I mean, I just couldn't believe that was going to work. And it did. It cleared out the prisons, and there wasn't a single revenge killing during that time. In fact, our office in northern Rwanda was in an abandoned tribunal, right? But my point here is that the United States has a serious problem of accountability, and particularly to the American descendants of slaves, and the Native Americans. So this is our history. If you move back from a place like Rwanda, and your children start studying in a public school, they're not getting the whole history of the United States. So all this to say is, if they can go through the Gachacha process in Rwanda and with no revenge killings, clear out their prisons and acknowledge and atone for, at least publicly, you don't know what's going on in someone's heart, but you can atone for something only after you acknowledge it. And I think Brian Stevenson's point is that just mercy, expert mercy in the legal and social cohesion sense, does require an acknowledgement of white supremacy and how it's shaped this nation, and indeed many other nations in the course of centuries. So again, some people roll their eyes when we say that, but I'm saying this in the most pragmatic manner, that we need this healing to promote social cohesion, not in small bounded communities that are like each other, but across the great diversity of this country. Now, that's just my personal view.
Thank you so much. And I know we're over time, but I just have to ask you this last question, which you talked about how shaming wasn't the right way to go about getting people to wear masks, and I tend to agree with you. But we are asking people for more significant sacrifices than just wearing masks. Grandparents are going out without seeing their grandchildren for months on end, maybe a year. Do you have a message for people about how to kind of find their inner source of compassion, of expert mercy, to do what we need to do for public health for the duration of this pandemic?
You know, I think that first of all, I'm learning so much. It's this past few months, and I'm also confessing some of my errors about Rwanda, telling you I didn't think that was possible. I didn't think this was possible. I didn't even believe that this many Americans would try and embrace social distancing, would stay at home if they could. So already, you know, I think that there's some impressive messages out there that people want to be safe and they want their family and their elderly grandparents, for example, you brought that up, to be safe. So we now know that that this is around this country in, again, radically different places. That desire to look out for other people is there, right? It can be tapped. So the message I would say, just like back to this expert mercy, is in this instance, expert mercy towards your fellow citizens and your families and your essential workers. Expert mercy includes this notion of pragmatic solidarity. And it's hard to say, you know, keep it up. But I mean, that's got to be the message if we're going to see an end of this first wave that doesn't really, it's still crashing upon us. And it's just, you know, I don't want to be socially distanced anymore. I can't imagine anybody does. But the fact that it can save lives is we're going to have to count on that being important to people. And I think it's important to people everywhere in the world. And I think it's the dominant sentiment if we cultivate it. And where did the response to George Floyd's murder come from? It's like people across the country, they didn't know him prior to his death, you know, but there's this response out there and looking for the purity of it and the positivity of it, of looking out for one another and saying, no, it's not okay, you know, to forget one another or trample on one another. I think there's enough of that out there in this country and in many others I've worked in to get us through. Unfortunately, it won't get everybody through, but I'm taking heart at the declining case fatality rate, right? New cases are up, deaths are down, and we need to keep doing whatever we can to both prevent new cases, but also to take good care of people when they fall ill.
Dr. Paul Farmer, thank you so much for joining us for this Op Talk. It's been a pleasure, and thanks to everyone for joining us.
Thanks, Bina, and thank you team there and Chris. And it's been an honor, and I look forward to doing another one.
I do too. Take care.
Bye.